Next, we are going to study about management of esotropia, optical correction, refraction, and proper perception, including using a bifocal, using of prism, purpose, fusion, and binocular vision, maintaining relationship between accommodation and convergent mechanism. Proper cyclopedia, proper prescription, full cyclopegic correction with no over or under correction, bifocal in case of high AZ by A ratio. Executive half segment bifocal photo is given. Using of prism, glass prism up to 7 to 8 prism diopter over each eye, Fresnel's prism up to 25 to 30 prism diopter. The Fresnel's prism principle, the Fresnel's prism much thinner than the conventional ophthalmic prism of a same power can be imagined to be the series of small plastic prism lies in just on a thin platform of plastic. It's given a Fresnel's prism is up and conventional ophthalmic prism is down. Next, medical treatment, myotosis, cyclopegia, chemo by Botox. Mitosis in accommodative esotropia, site of actions is ciliary muscles, facultative accommodation, reduced accommodation effect, hence reduced accommodation convergence. Mitotic agents are DFF, fluoxetine, iodine, bromidine. Described end result after using a mitosis is proper binocular alignment at all time, especially near work with accommodative task. Cyclopedia to make a patient absent full hyperopic correction to suppress accommodative convergence mechanism and simultaneous divergence. Using of Botox in infantile esotropia, this is still under the trial of Scott and MC Near. Infantile esotropia is aligned before the 6 months can have good functional binocularity, while the surgery effective for Botox in adult eye muscular is transverse effect of early infancy is permanent because of the change in the developmental maturity muscles. Infantile overcorrection may resets and ocular binocular balance is yielded better result ultimately. However, on a negative side, associated change in binocular oblique overcorrection, AV patterns, and DVD may be still required surgical correction. Surgical management is pre-OP evaluation, assessment of vision and amblyopia therapy, measurement of deviation. Choosing of surgery, general principle, weakening, strengthening, aim, symmetrical and non-symmetrical surgery. Principle to split the amount of surgery across two rectors rather than single large surgery is single muscles alone. If AV with oblique overaction, vertical shift and horizontal rectise and slight resection or resets can be done. Weakening procedure, resection, conventional handbag, adjustable vertical transposition of horizontal recti and slugging resections is retroeclaty and myopsia. Resection muscles are disinsert or reinsert to a point closer to the origin. Induced by sacroelastic muscles becomes less effective. Reinsertion is done with a arc of contact. Must resection defined by this functional quarter depend on a arc of contact. Max resection MR is 6 mm, LR is 8 mm in adult. Children's MR is 5.5 mm, lateral rectus is 7 mm. Minimum MR is 3 mm, lateral is 4. Handbag resection is done with long end of the suture between the set of resection and the muscles. This is indicate the supermaximal resection is induced and a difficult pass through sutures that posteriorly, or there are is risk of sclera professional in high myopes. Weakening effect is more than a conventional resection because of the central sac. The pseudotendon may be a inverse space out around the suture which may leads to lateral undercorrection. Adjustable resection ability to modify the position of new operative muscles or use adjustable switches indication a large angle of deviation where result may be incidence reoperation previous injury muscles inconvenient strabismus with diplopia when pursued post-operative result will describe mechanical limitation of disc thyroid or orbitopathy and maculofacial anomalies, subrate, invert, and all nerve palsy or DRC. Retroequatory palsy is faded posterior fixation switcher. Muscles are switched posterior to insert the further than it limit or arc of contact. This sort of lever arm and reduce the action of muscles in the field of action. No change in primary position if no resection is done alone with the faded. Given middle rectus 12 to 40 mm, lateral rectus 60 to 20 mm, SR. Superior rectus 40 to 60 mm, inferior rectus 40 to 60 mm, more effective on MR and least on LR. Indication no accommodative convergence excessive esotropia, nystagmus blotches syndrome, DVD, paralytic strabismus, DRS, additional weakening effect over reaction muscles. Strengthening procedure, resection, advancement, transpositioning of adjusting muscles. Resection, shortening muscles length making it more tight. Improve effective by raising a higher length tendons curve. Excessive tendons is part of the therefore the maximum limit. Middle rectus 6 mm, lateral rectus and 4.5 mm. Advancement is strengthening procedure whereby the muscles is reinsert close to the limbus, reverse of resection, and indication the correction of consecutive squint in a resection muscles in a paralytic squint in addition to resection. Thank you.